I will continue in French just as a political statement after that in English. Donc, je suis Chantal Fabiard, je suis coordonnatrice de recherche clinique à la direction maintenant qui s'appelle Direction des partenariats d'apprentissage et d'activation des savoirs, ce qui est partiellement des affaires académiques. Aujourd'hui, nous avons Natalina Wittich de l'école de l'Université de qui présentera de la recherche des impacts en sciences de la vision, résultat de la collaboration entre MAB et le milieu universitaire. Sachez que la conférence est enregistrée par le petit bout au centre. Il nous sert de caméra, speaker et microphone. Donc, une part de là. Et Walter va projeter ici à l'écran la présentation. Donc, Walter, Natalina, on vous aussi.
You're on it.
Hi, everyone.
Hi.
Hi.
Well, thank you for joining us today. We're really looking forward to sharing some of the outcomes of the projects we've been collaborating on for many years, really. I think, we talked about this when we're organizing this event. Sometimes it's hard to see the connection between research and, real world practice or problems, but we've been really lucky and collaborating together on projects for many years. And I think for me today is just as much as an opportunity for us to share the outcomes of many of those projects, also for you to share your own thoughts on, what you feel is important going forward, where there are maybe gaps to address or we would be able to collaborate together. We have students at the University of Montreal who work on projects each year. So there are opportunities very often to kind of collaborate if there are problems that you see when working with clients or in other areas. So definitely reach out if at any point. But, so most of you know me, but for those who don't, I'm Natalie. And we're sharing screen.
No, he's not sharing his screen.
Oh, we're not sharing screen.
It's okay, there's no one on.
Okay, all right. We'll share the screen so it's accessible to all sighted people. So I've been a professor at the University of Montreal since 2024. So from that perspective, my journey as a prof is shorter than Walter's, but in other ways, I've really been in this world for my entire life. Obviously, I bring the perspective of someone who is blind, and previously as a clinician, when I worked here and also now as a researcher, a lot of the questions that I ask are really informed by those insights. And I know that for those of you in the room who also bring that first-hand perspective, we've had this conversation before. I've been really lucky that I've had access to, all the services I've needed, positive examples. So, but because I'm part of the community and from the conversations I've had, even with many of you in the room, I know what can happen when clients don't have access to that and how it could fall apart. And so that really informs a lot of what I'm interested in. But I'm also a clinician. I worked here for several years as a vision rehabilitation therapist. And it was really there where a lot of my research interests were kind of developed. I saw very early on that there were few resources to support adults with acquired vision loss to benefit from state institution. And the conversations I've had with other SRDVs in the room here today have been really important to developing a lot of those projects. All right, so before I talk about two examples of these collaborations and some of the outcomes of those projects, I did want to say just a few words about the research that I do, so that if these are topics that interest you or you see ways where we kind of are linked, or interests or questions that you have where you feel we might be able to support each other to find interesting new solutions, feel free to contact me. In really, really broad strokes, I'm interested in kind of three aspects of the client experience. We think of it that way. I'm interested in the extent to which clients have the ability to learn different tools like Braille and assistive devices, the extent to which they're able to use those tools to participate in different ways. But then more broadly than that, the extent to which they're able to really become leaders in whatever field they choose to pursue. Because I know I'm speaking to the choir today, which we've talked about this informally in many ways, but we can give clients all the tools they need, but we know that there are other barriers that they encounter kind of more related to accessibility and inclusion. So I'm very interested in those aspects, especially as it relates to post-secondary education and employment. Next slide. So I've been talking a lot about terminology around site substitution. And for those of you who work already in the field, you'll know by site sub, I'm really talking about non-visual communication, so Braille, screen reading technologies, any audio-based devices. And I just want to point out here that often we think of clients who are functionally blind, but for those of you who are maybe less familiar with this specific area of vision rehabilitation, it really covers a broader scope of clients, from those with low vision to those who are just maybe at the legal blindness point to those who are functionally blind, because a lot of the time these tools really depend on the task that a client might be performing. And we know that's something that many of you will have talked about before, know about. All right, go to the next slide. No, it's really perfect. Hearing sound. All right, so I'm going to talk about two projects and some of the outcomes that have come out of these projects. And the first is around conference accessibility. This sounds like it's really, really specific, but it really touches on something that I know is a priority regardless of whether you work with clients of low vision or blindness, because we all know that the unemployment rate for all people with disabilities has really not changed. It's still really a really big problem, 70% or worse for clients with visual impairments. So this project was really looking at what are the barriers that people with visual impairments encounter, not only at conferences, but also other types of professional meetings. And so one of the things that I did early on was I collaborated with some other researchers from Canada and the US who also have visual impairments. And we developed kind of a little bit of a working group where we started organizing seminars, workshops to talk to people about accessibility and research and in higher education. And some of you in the room attended some of those presentations and shared your insights as well. And throughout 2022 and 2023, we actually co-developed a conference accessibility toolkit. So basically recommendations that could be used not just for conferences, but also other scientific or other professional meetings. And more recently, we launched an international survey to kind of explore some of those barriers that people encounter when they attend a conference or a meeting in greater depth. And what we're hoping to do is go back to that toolkit and update it to reflect some of the new insights we gained from that. So I'm really looking forward to sharing that with all of you in the coming months. So I'll talk just for the next 2 or 3 slides, some of the results from the survey. I am looking at my notes because there are some numbers here. So I have to thank those of you in the room in the Vision Rehab program who have been involved in different ways. You really helped recruit participants today with people you know, because we had a really good outcome, 99 participants, which is really high, I think, for a survey in our population between the ages of 18 and 74. Just a few details I'll share here. 78% were from North America, and actually there were quite a few from here. Again, thanks to all of you who have helped with recruitment. 63% identified as blind, 29% as low vision, and about 8% as deafblind. And then we also asked about access to information methods. So that kind of follows the same trend. We had about 63 participants who used screen readers, followed by Braille and then large print. We had a nice balance between students and researchers. So again, thank you for sharing and for those of you who participated as well. Next. I'll just share some of the results really briefly before I talk about the outcome. So if we look at access to information very generally, most participants, unsurprisingly, face barriers when navigating conference websites or other kind of academic websites as well. So a lot of those issues will be familiar to those of you who work in the field. Buttons that you can't activate with the screen reader, really poor contrast and font, no alt text, or in other words, written descriptions of images, especially when professional conferences or meetings are advertised on social media. And that is especially a problem for students and for people newer to careers who may just feel discouraged from participating at all because of those barriers. Next slide. So if we look at travel barriers, there's some interesting results that will be of interest to the O&Ms in the room. 61% of participants reported barriers related to costs during travel to conferences and other. So, bringing a sighted guide with you or having to kind of find alternative methods of transportation that may not be as cost effective. And a majority of those participants did not ask their employers for any additional support to offset those accommodations. And I think that's really important. I know I've had this conversation, with several of you in the room, but especially for students and new graduates who are newer in their career, they're a lot less likely to raise those needs because they don't really want to jeopardize their employment. And on site, there are the kind of typical challenges you can expect, challenges finding the hotel, registration desk, navigating in exhibitor halls and other venues at a conference. 75% of participants said that they were rarely able to locate exhibitors during a conference. And there were a subset of participants who chose not to participate at all in those social networking activities, which is really unfortunate because, again, if we think of employment, that's where we meet and we network with people who may become very valuable later on. Next slide. And then finally, I'm just highlighting a few results here more related to presentations at meetings and conferences. Participants felt that accessibility was rarely considered. Only 25% of organizers for meetings and conferences provided accessible formats of not just presentations, but also agendas, other types of material. And a majority also could not, access more visual content like posters. So the recommendations the participants highlighted are very similar to those that clinicians would highlight, and that many of you highlighted during different discussions we've had around, providing guidelines for accessible posters and thinking about accessibility proactively. But of course, to do that, you need to provide really clear, simple guidelines for organizers. Next slide. So before I talk about those outcomes, I'd like to really briefly talk about the Braille research I've been working on. Again, this is a series of projects. I'm only talking about one, but you've all been very integral to every part, not just designing the studies, but also what we actually test participants on in terms of their Braille-related skills. Go to the next slide. Before I talk about the Braille device research I wanted to highlight, I just want to highlight that in some of the previous studies we've collaborated on, there were other aspects, barriers that clients encounter that really delayed the start to Braille training related to stigma, stigma that they may hold or that the people around them may hold about the decision to actually use Braille because it discloses their impairment to others. So this will become really important when I talk about the outcome. Slide. All right. So the study I wanted to highlight explored the influence of different Braille display devices that exist. For those of you who work in this area, you know that Braille displays come in many different lengths. We have single line displays, we have full page displays, and the goal here is to really understand what factors should we consider when making these decisions, selecting the best device for a client. And this particular project was actually born out of conversations I had with clinicians. So it's a really nice example of our collaboration. It's an ongoing study, so we've tested 11 participants so far, kind of across the age spectrum, 18 to 72. And most of them were in Braille early on. And what we did is we essentially had them read Braille passages, paragraphs, and tables on all the various types of Braille displays, different lengths of Braille displays, but also full pages. That we can see, is there a difference based on speed? Because that might be one part of what we want to consider if we're developing guidelines to select the best device. Next slide. So I'll be presenting kind of more detailed results in the future, I'm sure. But just really briefly to show you what we can see already, the 40 cell display, which is kind of the midpoint length, is the fastest at about 4 characters per second. That doesn't sound like a big difference. The slowest is around 2 characters per second. But for those of you who know Braille, a character could be an entire word. So that can make a difference, particularly for things like education, where you want to be as efficient as possible. Next slide. Finally, I wanted to highlight some of the results when we looked at the single line and full page displays. And we found that the full page displays are especially helpful, as you would expect when you're seeking information on a table, especially for questions where you might want to compare 2 different columns on a table. There was almost a double difference in the number of seconds it required on average for participants to locate that information. So again, when we're thinking about RAMQ or how to help guide clients, this is really important. All right, 2 outcomes. We'll go to the next slide. 2 outcomes from this research. The first, I mentioned the conference accessibility toolkit. I've included a QR code here, which I can also share by email. I'll actually share all of these slides later on. So you can already see the toolkit that exists. But as I said, once we have the full results from this survey, I'm really happy to share that and get any additional feedback to work on a more updated toolkit that reflects some of the things that we've been talking about. So you can, definitely feel free to share this with employers and others who are around the clients that you serve. And we've had to have other ideas. The second is really exciting, and this stems from a lot of the Braille research I've done over the years, where clients and clinicians kind of highlighted, again, the benefit of knowing other Braille users, the stigma that can often be attached to Braille. And so based on what we learned from those conversations, through my involvement with Braille Literacy Canada, we actually developed the first online nationwide across Canada peer support program for adult Braille learners. So this isn't where clients learn Braille, but it's more where they could connect once a month with other Braille learners, just to share tips, support, and other types of advice. I have a really short clip that hopefully Walter you'll be able to click on from one of our participants. came from studies that might be from the studies we worked on together. So it's really exciting. And for those of you who are working with adult clients and you'd like information about that program, which is still offered, feel free to reach out. On the next slide, I have a list of just, I won't go through these individually, but other projects that I'm working on, many of which, again, have stemmed from even the informal conversations we've had together around Braille accessibility and inclusion. And again, I'll share these slides later on. And then finally, on my last slide, I list some of you who have helped and collaborated in different ways over the years, whether it's producing the Braille materials we use for studies, connecting us with others, other clinicians, recruiting participants, sharing ideas about important topics to pursue. And I also list the students that we've been able to hire. I've been able to take on as summer interns to work on the two projects that I've mentioned, thanks to the Rehabilitation Foundation. So that's also really exciting. So I will end there, but thank you again for coming.
Thank you.
Questions now? Yeah, okay. Comments, questions, experience to share.
Natalie, I think that peer support through the Braille literacy organization. I have a client right now in Braille too. I think he would really benefit from hearing how other people cope with learning and mixing up the letters.
Yep. Definitely. I will share that information.
I really appreciate that. Peer groups are always so helpful.
Yeah.
They are.
Not only I can't begin to tell you how amazing the projects that you've done are. I think I believe in this room, but I think to me especially that you're really a strong advocate in promoting independence and as well as Braille literacy. I think that is so important for people that are of any age, whether you're young, 6 years old, all the way up to 92.
Thank you. The same to all of you as well, you know, Mike, Maurice, others in the room who are part of the community and also are sighted friends too.
Yeah.
So once you have your results, we'll make sure to invite you
Definitely.
and have all the survey. And if you have other needs or to present on topics, just let us know at we'll ask you to present.
Done.
Invite me. Right? And more questions at the end. Psyche, Walter, or
All right, thank you. I will pick up on this idea of peer support because I realized there's something we did at the MAB a long time ago that has worked out really well. For those who don't know me, I'm Walter Wittich. I'm a colleague of Natalie's in the School of Optometry, and I am the former Chantal. I used to work here in the Chantal.
Wow.
Yeah.
Yeah, about 15 pounds ago. One of the things we did at the time is that we linked all the people that were in the lab here and that were working with us to create a Facebook group that we called No Vision. So this happened in 2012 when I started here. And then people just shared it with us. We were talking about research, we were talking about an event, we promoted various things. Today, this group has over 24,000 members. And I'm adding roughly 100 to 200 people a day. This is how this has exploded. It is not a private group. It is an open group. So whatever you post is visible to the world, which is why some people choose to post anonymously, especially when these are peers or questions that might be awkward or weird. We just had a really interesting conversation going on about the accessibility of breast pumps. So no stuff that doesn't necessarily come up over lunch. It is a fantastic group. If you are interested yourself, if you know somebody who wants to ask people things that you otherwise wouldn't, or sometimes it just rants or somebody finds a new device. So check it out. It's a really cool thing, and it really initiated here, and it's still going strong. The other thing that I wanted to do today, and this is more based on an interesting little presentation I had some of the people at the MAB when I started here. No matter what project you do, program evaluation, whether it's a research project or whether you're trying to introduce a new device to a client, the first thing people do is go online and search it. Right? You're searching literature or websites or any kind of info you can find something. It reminds me every time I do that we, by definition, global community, because the only thing we can find online is what somebody else bothered putting out there. So to me, that is really the motivation why anything we do here or we need to share with the rest, because it might be their starting point for where we're there. And so my presentation is a little bit more about how you are part of a global community, how you fit into it. Now, in my case, most of the work that I do with deaf blindness. There are a couple of people here that work in the deaf blind program. I recognize that it's true. You might be familiar with the Nordic definition, which is my favorite definition because it really focuses functional ability of the individual. With the team that I will show you in a moment, currently working on a global definition. It will include a medical perspective, functional perspective, and a perspective of identity based on the people. You can imagine how complicated this is when you want to do this across 6 regions. World Health Organization, but it's worth well its time. Our starting point in that team is the idea. Some of you are familiar with the PPH. Basically, the ICF is the global version. The joke here is that some of the people that developed the PPH are the same people that developed the ICF. And then they had a little bit of fallout and became 2. So Quebec is using the PPH and the rest of the world is using the ICF. But functionally, it comes with various definitions that I'm going to leave alone, but I like it as a concept of really viewing health in a social context. In my world, of course, all about deafblindness. Who knew dual sensory loss actually has an ICD code in terms of the International Classification of Diseases, even though it is not a disease itself, but it is specifically identified as a functional affective disease. And so when you look at something like assistive technology, which is considered an environmental factor, it can influence participation through something like communication, if you introduce a hearing support, a cochlear implant, whatever it may be, a strategy. So no matter what it is you do in your daily life can somehow fit into this model. Now, this model does something very weird. It's a book that used to be only available in paper. It contains roughly 1,400 codes for anything and everything you could functionally define in this model. For contrast, or for acuity, or code for speech recognition, code for you name it, right? It's anything and everything within there. Of course, who is going to memorize 1,400 codes? It's not very user friendly. So what we do with researchers in this model is we create something on course. Course set is a short number of codes from this model specific to a condition or disease. So what we've been working on is to develop a course set specifically to this. As an aside, there's a political mission in this. Lots of countries in the world that don't recognize deafblindness. So, for example, if you need access to tactile sign language interpretation, you fall through the cracks. So there's a political mission within it. In this case, we needed to develop the code that responds to give us a specific technology. There are 4 studies that we need to do. I'll do this in a moment to appease the WHO that this is real. And all of these studies need to have participation from each region. So you don't just do this in Quebec and Amsterdam, but you have to have. Once you do that, you have a consensus conference where you bring people together that represent these 4 groups as well, and then eventually you present your process. You ended up doing this for that time. Now, why would we care? In the ministry, there are people in insurance companies that make decisions over what is eligible to be on the ramp queue list. These people rarely know anything beyond the fact that we have 2 eyes and 2 ears and that they're in the front. Interact with ministries, whether that is education or health, funding agencies, my nightmare, right? Other non-for-profit organizations that may have the heart in the right place, but not necessarily the training to know what they're doing. They often look to things like these international corsets as a starting point for what they may cover or include in a policy. And you know from your job to justify. For me as a researcher, this is super interesting because we can find out what we haven't been studying, especially when people tell us this is hard. So this is what they pay attention. Here are the phases that we went through to develop the corsets. First one is a literature review of all things printed. This is really to represent what is current state of knowledge in terms of academics. It presents people like that. Second study is a qualitative study, but we actually talk to people that are living with deafblindness, all ages, all severities, across all continents. How we did this, that's a separate piece. It may require class. But what was really interesting is that for this step, we actually recruited people in Montreal from the dual sensorial program and from the program CISSS together with the other. The third study is an expert survey. This was done online and widely distributed. I also distributed this through the SLDV and O&M Google groups back then. You may have responded. Don't tell me if you did because I'm not supposed to know that. But I do know that there are responses from Canada because we could see from the IP codes that they were. The fourth step is clinical evaluations that were done by occupational therapists that work by Zoom to do remote assessment of people. Then all of these data get coded using the ICF system, supporting codes. That gives rise to a document that we presented at a conference in Spain last year. And then finally, we have the corset stuff. This is the team that conducted the consensus when we met in Spain. These are 30 people that represent researchers, clinicians, experts, people with lived experience, policymakers. They were from 19 different countries across all 6 regions of the WHO. These people are defined that they arrived with their communication support. The result are these. By the way, if you want this, you don't need to run your phone. Chantal has access to all. What is useful for you if you wanted to play with it? You go to the brief corset. It's only 33 items. If you have to do a quick and dirty assessment of somebody who has dual sensory impairments, those are the 33 items that the world agrees upon are the most important to assess. If you're a politician, you want to have the comprehensive because it will include all 218 priorities functionally, including things like access to vote. This goes across the entire spectrum. If you're communicating with a professional in a different specialty, an optometrist talking to an ENT surgeon, it is the intermediate course that covers roughly 100 priorities that are important to describe the function of that. So then we decided, okay, we've got all this info. Now what we do, we did a bit of implementation. The first thing that some of you might recognize here, we developed an English and French script that summarizes what interpreted in ASL. YouTube now. We then worked with the team posting up in Spain. They've already done presentation to their local government to specifically add certain services that emerged. There's a team in Sweden that focuses on children. They've been using the corset communication, incorporating them in the assessment of children that have communication. And one of my favorites is the team in Poland. Poland does not recognize the plans at all. They translated all our documents into Polish, sent them to the Ministry of Health, and they're now working on a recognition of service. So you guys, by contributing to this, are changing how things are. Now, because this is such a success, and because we realize the situation with kids is different, there are specific course sets that are tailored to the needs of age 0 to 17. We've now started to go through all those steps again. Some of you know my student Shirley. Shirley decided to take this on as a PhD project, and she will hopefully be able to present the course sets for deafblindness children in 3 segregated age groups that are based on the state for children, hopefully in 2 years. Some of you may have seen the recruitment for the expert survey go out in January. Google, but if you don't have it and you want to, let me. So it's a big thank you to all of you that have this process or that want to help as we go forward. That gave us money. Canadian Hearing Service, it's interestingly has a global partnership grant. It's made for things like improve global hearing. Still looking for the global vision. Deafblind International. Mission. But that also resulted in a website called Who's Deafblind, a bit of a WHO deafblind joke in there. And yeah, find us, ask us anything if you're interested. And thank you for your attention. Always